discussed about various pathologies related to rectum and anal canal, and we had stopped till pilonidal sinus. Today we are going to discuss about CA rectum, CA anal canal, and vermiform appendix, that is acute appendicitis. Okay, starting with CA rectum. So this is the most common large bowel malignancy site. So large bowel includes, as we all know, cecum, ascending colon, transverse colon, descending colon, sigmoid, and rectum and anal canal. Among all those, CA rectum is the most common site for cancers, usually seen in the 5th to 6th decade, and most common site of metastasis is to the liver and then to the lungs. Okay, so what is the chemotherapy regimen that we follow in case of CA rectum is FOLFOX IV, we can say. That is, FOL stands for folinic acid or leucovorin, F for 5-fluorouracil, and OX for oxaliplatin. Okay, so what will be the clinical features in case of a rectal malignancy or a rectal cancer? So rectum cancer andre ಏನಾಗಿರುತ್ತೆ, obviously there is a growth somewhere along the rectum. So because of this growth, mucosa is disrupted, and because of this there can be bleeding, and if there is bleeding here, that will be seen outside. So that is bleeding per rectum. Okay, and usually there will be diarrhea in the early in the morning with associated with blood. Early morning bloody diarrhea will be seen, and there is passage of bloody slime. That is, only blood with mucus can be seen without fecal matter. This can also be seen in case of CA rectum. Okay, so other clinical feature is spurious diarrhea. That is, every 2 to 3 hours rectum is full with discharge from the tumor, and so the patient passes stools like every 3 hours. So mainly blood plus mucus, and this mucus is because of cancer or the tumor. So this tumor fills the rectum with mucus and blood, because of which every 2 to 3 hourly once the patient is feeling like he has to go for defecation, and that diarrhea is called as spurious diarrhea. And also there will be tenesmus, that is painful defecation with sensation of incomplete evacuation. The person feels still he hasn't passed entire feces. He feels okay, still some feces is left, and it will be painful while passing the feces. That is called as tenesmus. Okay. Other complications include backache or sciatica. Basically, sacral plexus involvement will be there if the tumor has spread posteriorly, and that will lead to backache or sciatica. And then other characteristic features of all malignancies like weight loss, anorexia, will be seen in case if it is malignant and it has spread to other distant organs. Okay, so what are the investigations we'll do? So just like we know, length of the anal canal is 3 cm, whereas length of rectum is 14 cm. For complete evaluation, length of the instrument should be at least 17 cm. So what are the options available so that at least 17 cm can be evaluated? One being proctoscopy, other being sigmoidoscopy. Okay, colonoscopy, that is length of proctoscope is 10 centimeters. Rigid sigmoidoscope, these are basically asked in Viva practicals. What is the length of proctoscope? It is 10 centimeter. What is the length of sigmoidoscope, rigid sigmoidoscope? That is 25 centimeter. Flexible sigmoidoscope is more lengthier, that is 60 centimeter. Colonoscope, entire colon can be visualized, that is 160 centimeters. So investigation of choice hence being proctoscope cannot be used because it's only 10 centimeter. So investigation of choice is rigid sigmoidoscope, which is about 25 centimeters, and while doing rigid sigmoidoscopy we can take the chunk of the tissue, that is biopsy. Okay, so proctoscopy investigation options available, but actually performed is rigid sigmoidoscope, hence sigmoidoscopy is done. Okay, colonoscopy is mandatory for adequate evaluation of the whole colon to rule out any synchronous polyp or synchronous malignancy. Suppose, what is a synchronous malignancy? Suppose there is a cancer arising in the rectum. Similarly, there can be cancer in transverse colon also. Okay, so these synchronous means these two lesions are present at the same time. Okay, so suppose we got to know that the patient is having bleeding PR, and we suspected rectal cancer, and we did rigid sigmoidoscopy, and we were able to find a tissue, but we have to go for colonoscopy and look if there are tumors elsewhere or if there are polyps elsewhere. Suppose for example in case of FAP or HNPCC there will be multiple polyps. So these polyps can be missed, and this condition, just taking a biopsy and treating rectal cancer isn't sufficient. We have to find out the actual cause, and for that reason, even after doing rigid sigmoidoscopy and biopsy, colonoscopy should be done mandatorily. Okay. Synchronous means simultaneously, metachronous means later after surgery. Okay, these two terminologies are used. So synchronous polyps, simultaneously existing polyps. Okay. Other than this, what investigation we can do? We can do virtual colonoscopy, which is a 3D reconstruction colonoscopy using CT scan. Advantage is you can visualize outside the lumen also, and disadvantage is biopsy cannot be done. Okay. In head and neck malignancies and pelvic malignancies, overcrowding of nerves, blood vessels, and soft tissues are there. So, investigation of choice for staging for most of the head and neck malignancy is MRI. And for T staging, investigation of choice is transrectal urethrosound or transrectal ultrasound. Sorry. Okay. So, if this tumor spreads to distantly lying nerve, lymph node, or vessel, then it cannot be differentiated. Hence, sensitivity of the ultrasound decreases if the distance between the probe and organ increases. Lymph node stage ಮಾಡಕ್ಕೆ ಏನು ಯೂಸ್ ಮಾಡ್ಬೋದು? We will go for endorectal MRI. Okay, overall the best investigation for staging is MRI in case of CA rectum. Okay, so after all this, how will we treat the case of CA rectum? That is, what is the principle? Principle is, if it is in stage 1, then we'll just go for surgical resection of the tumor. If it is in stage 2 or 3, we'll go for neoadjuvant chemoradiation. Neoadjuvant chemoradiation is before surgery, we'll give chemoradiation. ಆಯಿತಾ? ಸೊ ಇಷ್ಟು ದಪ್ಪ ಇದೆ ಟ್ಯೂಮರು, chemoradiation neoadjuvant before surgery ಕೊಟ್ಟಾಗ it will regress to some certain extent. Okay, after this we will resect this and then again give chemoradiation. Okay, so this is neoadjuvant chemoradiation followed by surgical resection, so that there is downstaging of the tumor, and then this tumor can be easily resected. And stage 4 is neoadjuvant chemoradiation followed by palliation or surgical excision. Okay, so it stages henge adana we'll discuss. So yeah, this was about stage 1, stage 2 and 3, stage 4. Basically ಯಾವ ಸ್ಟೇಜು ಹೆಂಗೆ ಅಂತ ಏನು ಕೇಳಲ್ಲ, ಜಸ್ಟ್ ಆಸ್ಕ್ ಯು ದ ಟ್ರೀಟ್ಮೆಂಟ್. ಸ್ಟೇಜ್ 1 ಏನು ಮಾಡ್ತೀರಾ, ಸ್ಟೇಜ್ 2 and 3 ಏನು ಮಾಡ್ತೀರಾ, ಸ್ಟೇಜ್ 4 ಏನು ಮಾಡ್ತೀರಾ. Okay, so treatment of choice being total mesorectal excision. This is given by Bill Heald. Okay, significant length of the bowel removal around the tumor. This procedure involves this tumor ಜೊತೆಗೆ ಅದರ ಸುತ್ತಮುತ್ತ ಇರೋ ಒಂದಷ್ಟು ಬಾವೆಲ್ನ ತೆಗೆದಾಕ್ಬಿಡೋದು. Okay, removal of surrounding tissues up to the plane between mesorectum and presacral fascia, and this is known as Heald's polyplane. Okay, if the CA rectum is located 5 cm above the anal verge, then we'll go for low anterior resection. If the CA rectum is located at or below the 5 cm from anal verge, then we'll have to go for abdominoperineal resection. This is also called as Miles procedure. Okay, so it depends if it is less than 5 cm or more than 5 cm. Again, this is explained here. Low anterior resection ಯಾವಾಗ ಮಾಡ್ತೀವಿ? If the tumor is more than 5 cm from the anal verge. So anal verge we are able to see here. If the tumor is more than 5 cm, then lower anterior resection. If it is below or less than 5 cm from the anal verge, then we'll have to go for abdominoperineal resection. Total mesorectal excision is done in case of CA rectum. That is the treatment of choice actually. Okay, so coming to carcinoma of the anal canal. Okay, so most common histological type is squamous cell cancer, then basal cell, and then MM. Okay, most common site of metastasis is lungs. Okay, involvement in the perineal malignancies like CA penis, CA scrotum, CA anus, inguinal lymph nodes are involved. Okay, what are the risk factors for developing CA anal canal? So risk factors being low socioeconomic status, basically improper hygiene can also lead. Okay, other than that, smoking, HPV infection, HIV positive or immunocompromised state, and anal receptive intercourse, multiple partners, history of CA cervix or vulval cancer in case of females, initial growth in anus inside the lumen, later the growth is seen outside the lumen. Okay, in advanced malignancies in anus, they can infiltrate into bladder, vagina, leading to fistula, and if sphincters are involved, then incontinence happens. Basically, we need to know the relations of the anal canal. Okay, suppose I am drawing a female. Okay, so this is a transverse section. ಸೈಡಿಂದ ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಓಕೆ, ದಿಸ್ ಈಸ್ ಯೂರಿನರಿ ಬ್ಲ್ಯಾಡರ್, ದಿಸ್ ಈಸ್ ಯೂಟ್ರಸ್, ದಿಸ್ ಈಸ್ rectum, anal canal. Okay, so anal canal ಇಲ್ಲಿ ಇನ್ವಾಲ್ವ್ಮೆಂಟ್ ಆಗ್ತಿದೆ ಅಂದರೆ what all possibilities are there? So if there is a vaginal cancer or CS cervix, cervical cancer or vulval cancer, that can spread to anal canal. ಅದು ಒಂದು ರಿಸ್ಕ್ ಫ್ಯಾಕ್ಟರ್. ಮಲ್ಟಿಪಲ್ ಸೆಕ್ಷುವಲ್ ಪಾರ್ಟ್ನರ್ಸ್ ಇದೆಲ್ಲ ಏನು ತೊಂದರೆನೇ ಇಲ್ಲ. ಓಕೆ, other than that, bladder, if there is bladder cancer and suppose if it is in males, there will be no uterus, so directly bladder can spread to rectum and anal canal. Okay, and then there can be formation of a fistula, and then if the sphincters, external anal sphincter, internal anal sphincter ivella involve adre, there will be incontinence. Okay, so what are the clinical features in case of CA anal canal? Most common symptom again bleeding per rectum. Other than that, foul smelling discharge can be there. There can be an involvement of bladder, vagina and the sphincters, which I just now described. So because of this reason, if the sphincters are involved, there can be incontinence. Other than that, backache because of same old reasons, nerves involvement agutte. Alteration of the bowel habit can be seen. So these are the ominous symptoms of advanced cases. Okay, so most common site of metastasis here it is lungs. In those in CA rectum, it was liver. Hematogenous, so ಇದು lymphatic. Okay, most common group of lymph nodes involved are inguinal group of lymph nodes. So investigation of choice ಅಲ್ಲಿ minimum 17 cm ಬೇಕಿತ್ತಿಲ್ಲ, ಅದೇನಿಲ್ಲ. So direct investigation is possible and hence proctoscopy and we can do biopsy. Okay, treatment ಏನು nigro regimen, that is chemotherapy followed by neoadjuvant chemotherapy followed by radiation, that is 5-fluorouracil followed by mitomycin C and then followed by radiation. Okay, so AJCC TNM classification ಏನು ಹೇಳುತ್ತೆ? This is again for staging, ಆಯಿತಾ? American Joint Cancer Association you can say. Okay, so T ಅಂದರೆ tumor, so tumor in situ or carcinoma in situ. This is also known as Bowen's disease and anal intraepithelial types ಏನು ಬೇಸಿಕಲಿ ಬೇಸ್ಮೆಂಟ್ ಮೆಂಬ್ರೇನ್ ಇನ್ವಾಲ್ವ್ ಆಗಿಲ್ಲ, ಬರೀ ಎಪಿಥೀಲಿಯಂ ಮಾತ್ರ ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ, ಎಪಿಥೀಲಿಯಮ್ಗೆ ಲಿಮಿಟೆಡ್ ಆಗಿದೆ ಡಿಸೀಸ್. Okay, so then it is carcinoma in situ. T1 is size of the tumor up to 2 cm. If more than 2 cm up to 5 cm, T2. More than 5 cm, T3. T4 ಅಂದರೆ involvement of adjacent structures like vagina, urethra and bladder. Okay, so this is T staging. N, lymph nodes. N1A, that is metastasis to inguinal. Most common ಎಲ್ಲಿಗೆ ಆಗಬೇಕು? Just adjacent to that. So inguinal ಪಕ್ಕದಲ್ಲಿರುತ್ತೆ, ಅದಕ್ಕೆ ಇನ್ವಾಲ್ವ್ ಆದರೆ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಟು ಇಂಗ್ವೈನಲ್ ಆರ್ ಮೀಸೋರೆಕ್ಟಲ್ ಆರ್ ಇಂಟರ್ನಲ್ ಇಲಿಯಾಕ್ ಲಿಂಫ್ ನೋಡ್ಸ್, ದೆನ್ ಇಟ್ ಈಸ್ 1A. 1B ಯಾವಾಗ? ಟು ಎಕ್ಸ್ಟರ್ನಲ್ ಇಲಿಯಾಕ್. ಓಕೆ, 1C ಇಟ್ ಈಸ್ ಎಕ್ಸ್ಟರ್ನಲ್ ಇಲಿಯಾಕ್ ಲಿಂಫ್ ನೋಡ್ಸ್ ಆ್ಯಂಡ್ ಇಂಗ್ವೈನಲ್ ಲಿಂಫ್ ನೋಡ್ಸ್ ಆ್ಯಂಡ್ ಮೀಸೋರೆಕ್ಟಲ್. ಸೊ ಮೂರು ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ, ಎಕ್ಸ್ಟರ್ನಲ್ ಇಲಿಯಾಕ್, ಇಂಗ್ವೈನಲ್ ಲಿಂಫ್ ನೋಡ್ಸ್ ಆ್ಯಂಡ್ ಮೀಸೋರೆಕ್ಟಲ್ ಆರ್ ಇಂಟರ್ನಲ್ ಇಲಿಯಾಕ್ ಲಿಂಫ್ ನೋಡ್ಸ್. ಓಕೆ, ಅದರ್ ದನ್ ದಟ್ M0 ಅಂದರೆ ಮೆಟಾಸ್ಟಾಸಿಸ್ ಇಲ್ಲ, M1 ಅಂದರೆ ದೆರ್ ಈಸ್ ಮೆಟಾಸ್ಟಾಸಿಸ್. So this was about CA rectum and anal canal. ಇದಕ್ಕೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಸೇಮ್ ಲೈಕ್ ಎಕ್ಸೇಷನ್ ಆಫ್ ದ ಟ್ಯೂಮರ್ ಬೇಸಿಕಲಿ, ಅದು ಬಿಟ್ಟರೆ ಕೀಮೋ ರೇಡಿಯೇಷನ್ ಅಷ್ಟೇ. Anal canal is just like a passage, so you can't remove and all. So only thing you can do is this nigro regimen. Okay, ಏನಾದ್ರು ಡೌಟ್